Welcome to part 2 of this presentation on the hand. So we will continue to start with the finger and revisit some Salter-Harris fractures, buccal and condylar fractures as well of the fingers, and then we'll move on to metacarpal fractures, fracture dislocations and dislocations, some specific cases of gamekeepers and skier's thumb, and we'll also look at base of first metacarpal fractures, Bennett's and Rolando's. And then finally we'll just have a look back to the normal features of nutrient foramen to make sure that you don't confuse those with fractures, and wrap up the whole thing with an overview as how to search the whole image of the hand. Hope you enjoy.
Before we go any further, let's do a refresher on Salter-Harris fracture classification. This is the classification that we give for paediatrics when they sustain injuries to their growth plate or their physis. So let's just have a quick refresher over the anatomy. So in long bones or miniature long bones, the tubular portion of the long bone or miniature long bone is referred to as the diaphysis. Once it starts to flare out, this area here is referred to as the metaphysis. The physis separates the metaphysis from the epiphysis, and the epiphysis is sited at each end of the long bone or miniature long bone. Now it's important to appreciate that once a patient reaches skeletal maturity and that the physis closes, the entire end of the long bone is referred to as the metaphysis. So the epiphysis no longer is present in the adult bone. The entire portion of the flary portion all the way to the end is now referred to as the metaphysis. So patients sustain growth plate injuries or injuries to their physis in quite a specific way. A Salter-Harris 1 fracture is when you get a horizontal fracture through the physis, and this causes the epiphysis to slip off. So the second classification, Salter-Harris 2, this is where you have a fracture through the metaphysis. And it's important that this fracture through the metaphysis extends to involve the physis. If you have a metaphyseal fracture that does not involve the physis, this is not a Salter-Harris fracture. So a Salter-Harris 2 fracture is a fracture of the metaphysis that extends to the physis. And this is by far and away the most common fracture that you see in a paediatric. Now a Salter-Harris 3 fracture is where you get a fracture through the epiphysis that extends to the physis. It's usually a sagittally orientated fracture. Okay, so a Salter-Harris 4, this is where you have a fracture that extends from the metaphysis through the physis and out through the epiphysis. And finally, a Salter-Harris 5 fracture is when the physis is crushed by the metaphysis and epiphysis squashing it together. Now, as you can appreciate, a Salter-Harris 1 and 2 fractures, these are less serious and are more likely to heal well. Whereas a Salter-Harris 3, this starts to become a more serious injury and prognosis can be mixed. Once you get through to Salter-Harris 4 and a Salter-Harris 5 fracture, these really have very poor outcomes. And in 5 in particular is really very serious, because what happens is that with the crushing of the physis, this will actually lead to early closure of that physis. So say, for example, if a patient sustains a Salter-Harris 5 fracture to their distal radius, what will happen is the radius will stop growing at that point, but the ulna, the distal ulna, will continue to. So you get some really serious consequences from a Salter-Harris 5 injury. Okay, so here we have a Salter-Harris type 1 injury, and we can see here that the physis of the distal phalanx, we can see that the physis has been disrupted. On the DP view, if you look at the physis of the intermediate phalanx, you can see, and the physis of the proximal phalanx and of the metacarpal head, you can see that it's uniform, it's of a normal, quite thin physeal plate. But once you look at the physis of the distal phalanx, you can see that there's real diastasis there, indicating that there's been disruption. And if you look at the proximal metaphysis of the distal phalanx, you can see that there's no evidence of a fracture. So what's happened is that you have a horizontal fracture through the physis, and because this is a really slippy area, it's cartilage, it hasn't been ossified, it's very slippy, and what's happened is that the metaphysis has slipped dorsally in relation to the epiphysis. It's important to note that in the hands, generally speaking, you only have one physis for the phalanges, and the same for the metacarpals. So with the phalanges, the physis is situated at the proximal end, at the base, whereas generally speaking the physis in the metacarpals is at the neck, or the distal end of the metacarpal. So what is it? It's a Salter-Harris 1 fracture, where the distal phalanx, how dorsal slip. Here we have a Salter-Harris type 2 fracture, but I think this picture in particular is a really good example of why fingers and hands can be really quite complex because of all the overlapping structures. Let's have a look at the distal phalanx first. Here we can see the lucent line of the epiphysis, and then underneath, remember at the end of the long bones, you have the epiphysis. But we've got a slightly oblique view of that epiphysis because we're semi-looking at the undersurface. And if you look carefully, you can see what appears to be almost like a lucent line across the epiphysis, and what that actually is, it's the end of the metaphysis creating that sort of appearances, and it mustn't be misconstrued as a fracture. So you have to understand how all the overlapping structures can mimic lucent lines, which mustn't be mistaken. So let's have a look in more close detail at the epiphysis of the intermediate phalanx. So we can see our physis through here, which is our lucent line, and now we're looking at the epiphysis, which is slightly oblique view because of the oblique projection, and at the radial margin of the epiphysis you can see a little lucent line, and again this is the metaphysis or the adjacent metaphysis creating that lucent appearance. So that particular little area shouldn't be mistaken for a fracture. Instead, we can see quite clearly that the metaphysis, the proximal metaphysis, has got a break in the cortex, and if you look carefully, that break actually extends down to the physis. So because this is an injury isolated to the metaphysis, which involves the physis, it's a Salter-Harris 2 injury. Just have a quick look at the physis of the index, of the middle finger. You can see that there's apparent diastasis, and this is just down to the projection. It mustn't be misconstrued. So what I would strongly recommend you to do is to really familiarise yourself with the appearance or the normal appearances of a DP and a DP oblique hand, so that you're familiar with how the different overlapping structures appear. So what is it? It's a Salter-Harris 2 fracture, where it's the proximal metaphysis of the intermediate phalanx of the left ring finger. How? This slight angulation. We can see there's slight angulation because there's a little step in the cortex and there is slight, it appears slightly beaked in relation to the rest of the bone. So therefore you've got a slight degree of angulation. Now, there is actually a Salter-Harris 1 type 2 fracture. So what this actually is the Salter-Harris type 1, we know, is a horizontal fracture to the physis. And because the cartilaginous zone is very slippy, it causes the metaphysis or the epiphysis to slip, depending on which way it goes. And then what happens is with a Salter-Harris 2 fracture, you have a fracture of the metaphysis that extends to the physis. So here we can clearly see our oblique fracture of the metaphysis that extends to the physis. So therefore that's Salter-Harris 2. But now if you look at the proximal phalanx, we can see how it is slipped to medially in relation to the adjacent epiphysis. So this is why it's a Salter-Harris type 1/2. So what is it? It's a Salter-Harris 1 type 2 fracture where it's the proximal metaphysis of the proximal phalanx of the thumb. How? Slight angulation with medial slip. So here we have a Salter-Harris 3 fracture. Remember, a type 3 fracture is a fracture that involves the epiphysis. And if we look carefully, we can see the epiphysis at the base of the proximal phalanx, and that there is a fracture that extends to the physis, and there's a little bit of displacement through there. So this is your classic Salter-Harris type 3, not particularly common, certainly not as common as a type 2 fracture. So what is it? It's a Salter-Harris 3 fracture where it's the proximal epiphysis of the proximal phalanx of the right little finger. How? Slightly displaced. And here we have a Salter-Harris 4 fracture. If you look carefully, this line through here, this is our physis, and we can see our sagittal fracture extending through the epiphysis, and then that fracture line just moves obliquely out, and there's only a very small amount of the metaphysis that is involved, but it's still enough to be a Salter-Harris type 4 fracture. So when you look carefully, make sure that you can see if the fracture line extends out beyond the physis to see if it's a Salter-Harris type 4. So what is it? It's Salter-Harris type 4 fracture where it's the proximal metaphysis, the physis and the epiphysis of the proximal phalanx of the left index finger. How? Undisplaced. We can tell it's undisplaced because if you look at the cortex of the diaphysis running down into the metaphysis, it's completely in alignment, so there's no displacement at all, and consequently when you go round the epiphysis again you can see that there is no, here's the anterior rim of the epiphysis. We're just seeing it slightly obliqued there. So the sclerotic rim is the anterior cortex, and we can see how there is absolutely no displacement between the two fracture sites. So this is an undisplaced fracture. And finally, we have a Salter-Harris type 5. Let's have a look at the distal phalanx first. If you look at the physis of the distal phalanx, we can see that it's really lucent, it's very black. There's nothing, no osseous debris within it. It's a crisp, clear, lucent line. And if we look at the proximal metaphysis, it's in alignment with the epiphysis. There's no displacement, the alignment is perfectly preserved. So now let's look at the intermediate phalanx. Well, we can see there's a massive amount of splaying of the metaphysis, and if you look at the physis, if you compare it to the distal phalanx physis, we can see that there's now osseous debris within that unossified cartilaginous zone, indicating that this has been crushed, and we can see how the metaphysis and the epiphysis do not align at all. In fact, in this case, the metaphysis is displayed so far volally in comparison to the epiphysis. So we can really see how this injury has caused the metaphysis to crush down into the physis and cause this really bad disruption. So what is it? It's a Salter-Harris 5 fracture. Where is it? It's the proximal metaphysis, physis and epiphysis of the intermediate phalanx of the left little finger. How? It's crushed or rammed, you could say, but I think crushed would be more appropriate. Okay, so paediatrics have very malleable bones, as you can appreciate, because they're obviously growing. So quite often paediatrics get incomplete fractures. So you get torus fractures, you get buccal fractures, you get green stick fractures. And what this means is, with regards to buccal, it means that the cortex hasn't actually been broken, and what you're getting is, in essence, a buckling of the cortex, hence being called a buccal fracture. And what we have to be aware of, particularly in the hands and feet, is that actually paediatrics frequently get multiple buccal fractures rather than a single one. So if you see a buccal fracture of the phalanges of the hands and feet, then be very careful to scrutinise the corresponding bones, or the adjacent bones I should say, to make sure that it isn't in isolation, to check to see if there's a further fracture or several further fractures indeed. Now if we look at this, if we look at the DP view, it's very easy to see the middle, the proximal phalanx of the middle finger. If we come down the diaphysis on the medial border, we can see there is a buckling of the cortex, and crucially there's no lucent line that involves the physis, so we know that this is purely constrained to the metaphysis. There's no physeal involvement, so therefore it's not a Salter-Harris 2 injury. Now it's not quite so easy to appreciate on the index finger, but if you look at the proximal phalanx, if you come down the medial cortex of the proximal phalanx of the index finger, you can see how the metaphysis is slightly more sharply angulated in comparison to the opposing side. So we have to be really suspicious that actually there's another injury there. But once we look at our oblique view, we can quite clearly see in great detail of the two injuries that have affected the proximal phalanges. And so when we come down the medial cortex of the proximal phalanx of the index finger and of the middle finger, we can see this step or buckling within the metaphysis, indicating that there are fractures to this area. It's important to identify if the cortex is still intact, because it becomes a very different sort of injury. So a buckling of the cortex is a less significant injury than if the cortex is actually breached. So it's important to recognise whether it's just buckling or if there is indeed a complete fracture. So what is it? It's buccal fractures. Where is it? It's the proximal metaphysis of the proximal phalanges of the index and middle fingers of the right hand, and how it's slightly displaced. I love these radiographs. These are such a good example of why it's so important to do more than just one view. Let's start off with our DP view. Let's look at the interphalangeal joints of the index and ring fingers, and you can quite clearly see that they're very uniform. The joint space is equal all the way across, and you can see that there's no overlap at all. Now let's look at the proximal interphalangeal joint of our middle finger. So on the medial border, on the ulnar border, you can see that the joint space is maintained and it looks very normal. But then let's look at the radial border. We can suddenly see there's now diastasis, and that immediately should alert you to the fact that there must be something really odd going on here. Because if you have diastasis on one aspect of the joint and not on the other, there has to be disruption. Now remember, if you have a dislocation is when both parts of the joint are no longer in contact with each other, but a subluxation is when there will still be a degree of congruity of the joint space. So it might only be very little, but there will still be as part of the two aspects of the joints uniting or communicating with each other, I should say. Okay, so now let's look at the lateral view, and suddenly we can see just how deformed this finger is. So this is, of course, the volar aspect of our finger, and this is the dorsal aspect of our finger. And we can see how the intermediate phalanx has moved dorsally in relation to the proximal phalanx. Now there's no asset, so the head of the proximal phalanx and the base of the intermediate phalanx are not actually in contact with each other at all. So this is a pure dislocation. And if you look carefully, there appears to be a little spur adjacent to the volar cortex of the head of the proximal phalanx, and this will actually be a little tiny fragment of bone. So this is actually a fracture dislocation. So when you look at radiographs of dislocations, search carefully for any tiny osseous debris which might indicate that there's a further fracture. And it's particularly important to scrutinise this after post-relocation, because sometimes appreciating the fracture may only be seen on the post-relocation images. So what is it? It's a fracture dislocation, where it's the proximal interphalangeal joint of the left middle finger. That's the dislocation. And then it's volar to the head of the proximal phalanx, and that's your fracture. So how? It's dorsal for the dislocation, and then there's a tiny osseous fragment with regards to the fracture. Crush fractures to the ungual tuft of the distal phalanx are really very common. The ungual tuft is that semicircular bit at the tip of the distal phalanx. And if you get a crush fracture to the the ungual tuft, a crush fracture by definition is a comminuted fracture. So you don't need to say that there's a comminuted fracture. You don't need to say there is a comminuted crush fracture of the ungual tuft, because what you'll have essentially said is there's a comminuted fracture of the ungual tuft. So you can just say it's a crush fracture, and that will alert the referrer to the fact that there is numerous fragments. The nice thing about the ungual tuft is there's a reticulum that surrounds it, so actually these crush fractures are really significantly displaced. So what is it? It's a crush fracture. Where is the ungual tuft of the right index finger? How minimally displaced? It's possible to get undisplaced fractures of the phalanges. So when you look, you need to actually look at the bony architecture within the bones, as well as just looking at the cortex to see if the cortex is broken. And we can see this very lucent line through here. Now, although you have two fracture lines, please don't call this a comminuted fracture. The reason being is that if you say comminuted, that implies multiple quite large fragments, and the orthopaedic surgeon would then be thinking that they would need to actually line these separate fragments together and to hold them in place. Whereas here, although although you have two lucent lines, there's going to be absolutely no involvement with no surgery needed, because if you just put this patient in a splint, it'll heal very nicely. So please only reserve the term comminuted for fractures where there's gross displacement of large chunks of bone. I think another thing that I would like to draw attention to, sometimes, frequently in the hand and in the feet, you get so many overlapping soft tissue structures. If we look at the ring finger and the little finger, we can see at the base of the proximal phalanx, we can see this lucent line of the soft tissue structure, and sometimes these lucent lines of the soft tissue structure actually overlap the bone, and they can be mistaken for a fracture. So the key is, if the lucent line passes out through the bone into the surrounding soft tissues, you know that it's artefactual and it's not actually a fracture of the bone. What happens is, why we get these kind of lucent lines is because it's of a Mach effect. So a Mach effect is when you have two different densities that are superimposed, and what happens is that where the two different structures meet, you get this impression of a lucency. It's a trick of the eye as such, and so it's not a true fracture. It's not a genuine fracture line at all. Perhaps the most common Mach effect that we are familiar with is the effect of the overlapping incisors on the peg, creating the appearance of a fracture to the peg, and it's not, it's just the teeth. So what is it? It's a fracture where it's the diaphysis of the proximal phalanx of the right middle finger. How? It's undisplaced. Synovial hinge joints have condyles, and this is the same for both the head of the proximal and intermediate phalanges of the fingers. So we can see that there are two condyles at each head. So it's perfectly possible to get a intercondylar or bicondylar fracture. And here we can see that there is a lucent line that bisects the condyles and comes out to the midpoint of the diaphysis. So this is an intercondylar fracture. Now, the important thing about this is that it's completely undisplaced, so there's no difference in alignment. So hopefully, with luck, if this patient's splinted, it will heal them well. So what is it? It's a fracture where it's intercondylar of the head of the proximal phalanx of the left index finger, and how it's undisplaced, and always the most important thing is that it's intra-articular. So now we have a unicondylar fracture. So therefore the medial condyle, or the ulnar aspect of the condyle of the head of the proximal phalanx, has got a fracture and it's slightly separated off. So it's completely taken off one condyle. You can see, if you look at the articular surface, we can quite clearly see that there is a step, hence indicating that it's slightly displaced. And this is a more significant injury than the previous one, which was undisplaced. What is it? It's a fracture where it's the unicondyle of the head of the proximal phalanx of the right index finger. How? It's slightly displaced. Here we have another condylar fracture, and at first glance it looks very similar to the previous one. It's a larger fracture fragment, there's more displacement, but otherwise it looks pretty much similar. There is a sort of a lucency through the radial portion of the radial condyle, but it's not terribly clear. So let's now have a look at the oblique view. And now suddenly all is revealed on our oblique view, and here we can clearly see that actually both condyles have fractured off. So this is a bicondylar fracture. Because it's a bicondylar fracture, by definition it's a comminuted fracture, because you have 1, 2, 3 portions of fractures. So what is it? It's a fracture where it's bicondylar of the head of the proximal phalanx of the right little finger. How? It's slightly displaced. Metacarpal neck fractures are very common. Fractures that occur to the fourth and the fifth metacarpal necks are often incorrectly referred to as boxer's fractures because they're usually sustained from a punch injury. The thing is though, professional boxers actually fight with a straight fist. So if a professional boxer breaks their neck of their metacarpals, it's usually of their second or third metacarpals. Conversely, people who don't know how to fight correctly, or I shouldn't really promote fighting, but people who don't know how to box correctly, they fight with a curled fist, and so therefore what happens is that they get a fracture sustained to their fourth or their fifth metacarpal. Let's have a look at these metacarpals. Look at the second metacarpal neck, the third and the fourth. You can see how there's a smooth curve of the metacarpal as it sweeps down to the diaphysis of the metacarpals. In comparison, let's look at the fifth. We can see that there is a sharp angulation, and in fact if you look carefully there's actually a break in the cortex. Almost invariably, in fact I can't even think of a time where I've seen anything otherwise, they all have a degree of volar angulation. So it's important that when you talk about this fracture, you make sure that you describe the correct anatomical location, the metacarpal neck, and to make sure that you comment that there's volar angulation because that will need to be reduced. So what is it? It's a fracture where it's the neck of the fifth metacarpal of the right hand and how there's slight volar angulation. It is possible to sustain undisplaced fractures of the metacarpals, and if you look very carefully we can see that we have spiral fractures of the diaphysis of the fourth and the fifth metacarpal. So a spiral fracture is when it curls around the bone as it moves all the way down, a bit like if you think of a helix. So that's when you describe it as a spiral fracture. An oblique fracture is when you literally have a single fracture line that doesn't curl around the bone and it literally is at an oblique angle. So in this example, this is a really good example of spiral fractures. So always scrutinise carefully to make sure if you can see any lucent lines, and as I said, it's important that if you ever see a fracture to make sure you keep searching the rest of the film so that you don't miss any further injuries. So what is it? It's a fracture where it's the diaphyses of the fourth and fifth metacarpals of the right hand and how they're undisplaced and they're spiral. Gamekeeper's thumb is a valgus injury. We don't really see Gamekeeper's thumb anymore. What it is it's a chronic repetitive strain injury to the ulnar collateral ligament. And it's very uncommon these days. It used to be caused by gamekeepers breaking the necks of rabbits, and because they did this repeatedly over a prolonged period of time, it created laxity to the ulnar collateral ligament. These days it's more likely to be an acute injury with associated avulsion fracture. Now this is called a skier's thumb, and it's most often occurs with skiers who sustain an injury where they have the ski pole handle wrapped around their thumb, and that's what causes that valgus injury when they fall. Okay, so this is a left thumb. So on the lateral aspect, this is the radial aspect of the thumb, and this is the ulnar aspect of the thumb. So the ulnar collateral ligament inserts into the ulnar corner at the base of the proximal phalanx of the thumb, and what happens is that it just the tendon, just the ulnar collateral ligament, pulls off that little fracture fragment with the skier's thumb. So what is it? It's a fracture, it's a skier's thumb, where it's the ulnar collateral ligament insertion at the base of the proximal phalanx of the left thumb. How? It's slightly displaced. There are 5 different injuries that you can sustain at the base of the first metacarpal. The 2 intra-articular injuries are your Bennett's and your Rolando's. Your Rolando's is a comminuted fracture, whereas your Bennett's is an isolated oblique fracture of the base of the first metacarpal. The extra-articular injuries are your transverse fractures and your oblique fractures, as well as your Salter-Harris 2 in your paediatrics. With the oblique fracture, it's important to recognise if it extends to the articular surface, and therefore it would be an intra-articular fracture, or if the articular surface is preserved and therefore it becomes extra-articular. A pure Bennett's fracture is actually a fracture dislocation or fracture subluxation. This actually isn't a subluxation at all, because I think there's only a small amount of displacement here. What happens is that you have an oblique fracture of the ulnar corner of the base of the first metacarpal. And what happens is that the adductor pollis longus, which inserts radially, it pulls the metacarpal dorsally and radially, causing that subluxation or that dislocation. But if you look at the articular surface of both sides of the fracture line, you can see that there isn't much displacement. So in this particular instance, we would just say that there's only slight displacement rather than a subluxation, and it certainly isn't dislocated. So what is it? It's a Bennett's fracture, where it's the base of the first metacarpal of the right hand, and how? It's intra-articular, very important to comment on that, and there's slight displacement. A Rolando fracture is a comminuted fracture of the base of the first metacarpal. It classically forms a Y-shaped or T-shaped configuration. This is a highly unstable fracture, and so it's very important that you identify if there's more than one fracture fragment, as this will change patient management. So what is it? It's a Rolando's fracture, where it's at the base of the first metacarpal of the left thumb, and how? Comminuted and slight displacement. If you ever have a query to a fracture to the base of the metacarpal or a dislocation to the base of the metacarpal, you must always do a lateral view. Let's have a look at this image on the left of a normal DP hand. We can see that there is a joint space between the carpo-metacarpal joints, and we should clearly be able to visualise that joint all the way across. There may be a degree of obliquity with regards to the fifth carpo-metacarpal joint, but you should be able to see a degree of joint space, certainly radially. So when we look to see that that joint space is all maintained, that means that the metacarpals are in alignment. Now, if you get a dislocation, now most dislocations of the metacarpals involve the fourth and the fifth metacarpal. And if we look at our image on the right, we can suddenly see how the base of the fifth metacarpal and fourth metacarpal is now overlapping the hamate. You've got that increase in density. So not only do you have a loss of the joint space, but the increase in density indicates that there's overlap. And this will be the first subtle appearance that you're looking for with regards to a dislocation. Now the ligaments of the volar aspect of the carpometacarpal joints are very, very strong, so most metacarpal dislocations at the carpometacarpal joint are dorsal. Okay, so now let's have a look at the lateral view. This isn't a particularly good lateral, in fact it's far more of a very steep oblique, but we can immediately see how the fourth and the fifth metacarpal are displaced dorsally in relation to the normal alignment of the third and the second metacarpals, and it becomes immediately apparent on this view that actually there's a large fracture fragment to the hamate. When you have metacarpal dislocations at the carpometacarpal joint, it's really, of the fourth and the fifth metacarpals, it's really important to evaluate carefully if there's a further injury to the hamate, because frequently, as in this case, they are associated with hamate fractures. And sometimes it's only the lateral view that really can help you with regards to analysing the hamate injury. So what is it? It's a fracture dislocation where the fourth and fifth carpometacarpal joints, which is the dislocation, and the hamate, which is the fracture. How? Dorsal. I just want to draw your attention to nutrient foramen. We have them in all sorts of locations in our body, particularly in the femur. We see them in the tibia and the phalanges and the metacarpals and metatarsals, and they mustn't be misconstrued as a fracture. You will only see them in one view. If it wraps around the shaft or the diaphysis, then you know that that has to be a fracture because you will only see it passing obliquely. It will not actually breach the cortex, so our cortex here is completely intact. It tends to be a light grey in colour as the nutrient vessel comes in to feed the medullary cavity, and it should not extend out beyond the medullary cavity. So familiarise yourself with this this classic appearance, and that will help guide you towards not making a mistake by overcalling it as a fracture. So we've come to the end of the hand presentation. So what I want you to make sure that you review for every hand x-ray is to check around the outline of each and every bone. You must do that, that's really important, otherwise you will miss fractures. Check for interphalangeal joint dislocation. Always check the congruity of the joint's base reduction. You want to make sure that you have a nice uniform joint line. There's no diastasis at one part of the joint and no narrowing at the other. Check carefully for any undisplaced spiral fractures of the metacarpals, and check very carefully of the bases of the fourth and the fifth metacarpals for dislocation.